Kim Osborne, and followed by anesthetic procedure in pre, during, and post-operation of obese pregnant woman by Dr. Anuraj. Without further ado, ladies and gentlemen, please welcome the first subject, Dr. Kim Osborne. Time is yours. Please give a round of applause.
Do I stand or
Sit or stand?
you can stay?
You can stay.
I can see the.
Yes.
Thank you very much for inviting me to give this visit to your hospital and also to give this lecture. So thank you very much. I really appreciate coming and visiting. That's it. So I want to talk a bit about physiology yeah. And they're the topics I'm going to cover. There might be a little bit of cover crossed with Anu's talk, but it's always good to have a bit of repetition of information. So they're the things I'm going to go through. Thanks, right?
Yeah, you want to.
No, whatever.
Yes.
Yeah, next one. Okay, great. Okay, so the definitions of obesity, it is probably important to sort of understand those definitions. And when I'm talking about the different types of obesity, when I look around in Indonesia, there are too many of these. Where I come from, there are a fair few. So some of the data that I'm going to present on talks about people who are obese. And it probably is mainly in this group in Indonesia. So it's important just to think about it. I know where I work, 6% of the patients are that. Okay, so some of the slides I will show, I don't know how many of the population in Indonesia are greater than 40, but it's important. So what we do, we're in our antenatal clinics, they do the BMI on all the patients. So we know, we can classify. So just going about one of the effects related to the pathophysiology of pregnancy, that there's higher maternal deaths, thromboembolism, gestational diabetes, put all the list of those conditions there that affect both the mother and also the baby, because in obstetric anesthesia, we end up having two patients. One comes into the theatre, the other one's inside, and then at the end of the operation. There are two patients, but sometimes there are three, hopefully, but very rarely there might be four. But we always need to think about the neonatal effects as well. And so a really good reference is that later article there from 2019. So I did look at some of the trends related to make it specific to what's happening in Indonesia. And I know this data is now 10 years old, but it's still probably relevant. And it was a longitudinal study done by actually people from New Zealand associated with from Indonesia as well. So look, that's just a methodology that they use, and they were selecting and reviewing patients at various stages. So this is back here. Oops. Oh, I've done. Oh, yeah. Okay, so back in, so they started in 1993, and they surveyed, took observations on patients. Then they observed them again 6 years later, and then observed them again and recruited other people. And the last one of the observations was done in 2014. And this is what they found in that population. And what they showed was that, and if you look at the numbers down here, that the percentage of people that were their BMIs, and remember what I was saying before about this is overweight, BMI, they've got 25, but the obese is, they've got obese there as 25. So we need to understand, that's not, the definitions on the side aren't quite what I had before. So it's important when you review articles to look at what they're actually saying. But there is a trend, obviously, at that point, of the population in Indonesia getting more obese. And the group that was particularly the patients over 40 to 49 were getting, they were the ones that were getting bigger. I mean, they're all really getting bigger. Now, the other source of data that they looked at was the distributions of the weight over time. And so, back at the beginning of the survey, the figures were quite narrow, the distribution was quite narrow. And then when they did it in 2014, it's gone like this. So you don't want to be dealing with these patients here. And so that's BMI 30 and BMI 40. So in Australia, that figure would be up here, would be greater. But always there's a potential in Indonesia. We do know that group there's a potential for that to get bigger. So that's just some other looking at the children. So I think that's more epidemiology, and I was supposed to be talking about physiology. So then that's just the other bit about there's a world atlas of obesity that produces figures on all the countries, on many of the countries around. And this is from last year's atlas. And there's a couple of pages on the data from Indonesia. And what they were showing was that in men, it was, these are what the predictions were, that it would get increase. And it's the boys that they were going to get bigger, and then the women also. And what happened, what a girl, the girls that are today, or in 2030, they'll be 2035, they'll be the pregnant women. The company begins later. So hopefully Indonesia's keeping control of the weight. In Australia, everyone eats Macca's and KFC. I don't know if you have KFC.
Same with us.
Same with you, right? Okay. So anyway, so let's go on to the cardiovascular effects. Now, I hope this isn't an exam question, but this is a formula for estimating the circulating blood volume in obese adults. So it does, it's got this 70 at the top, the average weight in kilograms, and then it's got the BMI divided by 22, and it assumes that the patients have a circulating volume of 70 milligrams per kilo. So that's how they actually work out what the blood volume, estimating what the blood volume, because it does increase as people change in size. Because I say to our trainees, beware the little Thai woman or someone from Nepal, as opposed to our patient who's 140 kilograms. Because we might have some of those patients who are 45 kilograms. And if they have a PPH, and everyone's seeking, PPH of 2 litres or a litre, say a litre and a half, in a bigger patient, the physiological effects might not be as great as this for the patients who are smaller. So that's a figure. And then in the Journal of Obstetrics and Gynecology a few years ago, they did a complex study. And I won't go how they did the study, but there's obviously a higher volume in the lean pregnant women than the non. But the study was done in only 30 patients, and then in obstetric anesthesia, a couple of years ago, they did another study or review of looking at blood volumes, and they sort of came up with because we also know that when patients are pregnant, their cardiac output increases and their blood volume doesn't increase associated with the pregnancy. So they said, right, well, in a healthy pregnant lady, the blood volume actually is 95, and then overweight, they just about 85 and 75. So we always have to, I always sort of talk, the blood volume of a normal patient is 60 mils per kilo. So just going over that, but then when they're pregnant, that increases. So we're not dealing, but then when they're overweight, you probably might need to make some adjustments on it. And that's the graph that they had of. Because it's always tricky in an emergency with the PPH doing the calculation. Sometimes it might be better to think of it on a graph, put it on a graph. Anyway, so they've mapped what the total blood volume is. The volume with 30% blood loss, 30% blood loss, and 40% blood loss. Oh, that's a bit complicated, but I think just put it at the table because you might want to actually use the table to calculate. But in emergency, you sort of judge it a bit. But because in emergency, coming and looking at that, that would be actually really difficult, wouldn't it? Now, so we said the other thing they've got is cardiac output. As you know, the blood, the flow rate in all the parts of the body is different. The brain, the heart, greater than the muscle, the kidneys, and then least of all, the fat. So the cardiac output in 100 grams of fat is about 30 to 50 mils per litre. But it does that, when it is add to the total blood cardiac output. So that can also have therefore effects on the left ventricle, causing hypertrophy. And with pregnancy, you'll get an increased heart rate, and that may then decrease the diastolic interval and affect the myocardial perfusion time and lead to problems. And then there's also the deposition of the fat into the actual myocardial muscle that can have adverse effects as well. So it's not just blood volume, but it's actually, think about the myocardial cells. Then we always have to remember in obstetrics about aortic cable compression and its effect on venous return, or actually including the including the venous cable. So if you've got a little, not much fat, but if you've got a big, enormous pannus, that will be causing greater weight on the venous cava. So it's particularly important when you're doing a cesarean section, if they then, because don't forget, they have to actually operate and get into the uterus. So they've got the big pannus sitting there. They have to push it up and get under. And so the pannus can also create more obstruction of the IVC. And I've seen it where, and the other thing often, I've seen an obstetrician have difficulty because of the tilt, they push all this weight over centrally so they can get access. And then the patient's starting to go, I feel vomiting. And also with that patient, the pulse rate started to go down. I say, stop it! Stop pushing the, we have to have the lateral tilt.
Yeah.
And there are some of this case review in the UK, and I'm sure that the patient almost had a KUS, and I'm sure it was related to the PANIS. Hopefully you don't have patients like that, but you could. So it's always important to think about it. Respiratory, we know the physiology or the mechanics of respiration with the tidal volumes, and importantly, the residual volume and the expired reserve volume. Because those volumes actually, if they're there, blood will be circulating during respiration to those areas and helping with oxygen transfers into the pulmonary circulation and then to the rest of the body. So, that's just the same diagram showing the various vital capacity, the various lung volumes, which is your basic physiology. By the way, do you use West's respiratory physiology as a textbook? Yeah. So West, guess where West came from? Where he was born, where he went to medicine, where he did his medical training. He did his medical training actually in Adelaide. But I know that he travelled around and wrote his book when he was in America. Okay, so, and the other thing is that in the obese patient, we've got these are in the left, but in the pregnant, you can see the respiratory reserve volume decreases, and as ventilation's decreased. So there's also reduced airway diameter, and so that can affect adversely respiratory function. And the closing capacity there is what happens, what I was describing before, where you've got the alveoli allowing gas exchange, and then there's closing capacity. So it's all down, and so there's less exchange to the circulation. So we've got an obese patient, then we actually lie them flat, which worsens things, and then we anaesthetise them. That also makes it worse. So that's how they'll be ventilating normally. Obese awake and obese anaesthetised. That's with the general anaesthesia. It's one of the reasons why using regional anaesthesia in these patients is a good idea. I know you practice regional anaesthesia. One thing, of course, you know all this because you do lots of regional, but with a spinal, sometimes the patients, because they can't feel their chest moving up and down, sometimes they can feel a bit short of breath. And I know you teach them all, how to explain to the patients feeling on their chest that they are still breathing to reassure them. Okay, so respiratory, I've said, reduce FRC, increase closing capacity. There's the restricted changes associated with that. And because the chest wall compliance, if they've got a big abdomen, and also the chest, there'll be reduced chest and lung compliance. Some of them also may have sleep apnea, which might then also have effects on the pulmonary circulation, cause pulmonary hypertension. So that's just talking about the mechanics, but also in the airway, there'll be increased adiposity, as well as that's in addition to the normal increase in tissues and edema associated with pregnancy itself, and also down there the PQ mismatch. So I've just mentioned, I'll just go over again about the hyperemia that occurs normally, and remember when patients are pregnant, their respiratory drive is increased. So there's increased minute ventilation. So there's an increased drive. But it is actually difficult for them to sleep on their back, so they sleep on their side. So the mechanics, we've actually got them lying on their back. The work of breathing, so there's more energy required, which will increase the oxygen requirements and the demands. And then we've got the limits of movement, the total body. And then we've got the increased demand, and with intubation, there's a risk of desaturation, particularly with these obese patients. So there is this, and as I mentioned, when they suddenly push the penis up, that will also increase or decrease the compliance of the chest wall, which will make more likely to hypoxia. And that's in addition to what I was saying about venous return and effect on cardiac output. So we've got two things on the penis. Okay, so will also decrease the compliance of the chest wall. And then as I mentioned before, the edema of the lips, the tongue, the nasal passages. And we have patients that have got these big necks as well. So you do need to be careful and strong with if you do need to intubate these patients. And of course, there's sometimes with a spinal anaesthetic that you do need to convert from the spinal to the general anaesthetic. And it's in the middle of the operation. So it's important. I only will discuss that. This is more about anaesthesia. So I better skip. So anyway, that's what Arnold will be talking about. We would just emphasise, he's got a slide of this, but that's sort of the sniffing position. Then we've got our obese patient. We need them like that. And also sometimes the breasts in this position, the breasts will go up here, which makes it difficult. So they do sometimes use the round position. But anyway, it's more for others to discuss. Oh, that's anaesthesia, so we'll skip that. So there's also effects on the GI system. We know when they're pregnant, there's greater risk of them getting reflux because they all in Australia they all have reflux, but when they're obese, it does get worse. In the obese patient, there may also be effects on the liver and getting fatty liver, and that may therefore have some potentially, if it's more significant, with the pharmacokinetics or dynamics of drugs, and make them more risk of getting fatty liver or gestational diabetes. Also with the renal, with the obese patients, there'll be greater renin-angiotensin enzyme at level and sodium retention, and the glomerular filtration rate may actually decrease. So that makes them more likely to potentially get some mild renal adverse effects. But also, I'll get onto the other picture. Get onto the next thing. Endocrine. They've got a peripheral insulin resistance, so they're more likely to get gestational diabetes, which does affect the growth of the baby or the size of the baby, which may therefore mean they'll have more likely to have reduction of labour in Australia. And if the babies get bigger and the induction of labour has failed, then cesarean more likely to have cesarean section. So we know if pregnancy is a hypercoagulable state, so they're more likely to get pulmonary emboli or thromboembolic disease. But if they're obese, they may not move around as much. And so also if they're a bit hypoxic, then they'll get an increased hematocrit. And their immune defence may be affected and more likely to get chest infections. So pharmacology, we have to think about, what weight do we use when we're calculating drugs? So they've suggested here, this is from the World Foundation of Anesthesia, they've said total body weight. They use procalcitonin, thiopentone, propofol, the opioid, using lean body weight. Because we don't, if you have to give a general anaesthetic, you don't want using their total body weight. You don't want the patient to be narcotised at the end of the procedure because you're giving them a dose determined by their actual body weight over their lean body weight. And then there's also the ideal body weight. We're looking at non-depolarizers and non-steroidal drugs. And I mean, cesarean sections do have a rate of infection, and we don't want patients to have wound infections. Least of all, if they're obese and they've got this palace there, and it's all hot and sweaty, and so they're at increased risk. So if you think that you're a little antibiotic molecule and you want to get to the wound, what's the blood flow from the capillaries to actually the tissues of the skin or whatever? So in Australia, we've got this rule over 120 kilograms. We use ketozoa. We actually increase the dose. So it's important to think about the pharmacology. As I mentioned that before about decreased mobility and the obese patients, because of the tissues, they can be difficult to put in veins. Blood pressure monitoring. We have patients that you can't fit the blood to. You need to make sure you get the right size blood pressure cuff of these for obese patients. Now, this is going to anesthesia. This is actually from New Zealand. So they have a lot of islanders from Tonga and Samoa and Cook Islands. Yeah. And when you look at that atlas of world obesity, the Tongans and the Samoans, they're up the top. Yeah. Of obesity. And so what they did in this patient, they actually used some tape to push the adiposity around laterally. Because if here it's all, but they pulled it around. Some people actually use Langer's lines, where they sort of pull it up to make it easier. So this is anesthesia. The depth of the epidural space increases obviously with, but you also there's a different distribution of weight of adipose tissue in all patients, and some of the weight down here, or on the legs, some of it's up here, but I hate it when it's all down the back. So although we've said that's just a general thing, it's just actually looking and feeling, and also possibly using ultrasound. You use it. You've got lots of ultrasounds, so you're probably better at doing ultrasounds on the back than I am, because I'm older. And Arno's probably very good at doing it. I can do it, but I'm not great. So increase its early access. The other thing is, of course, when you're doing the spinal anaesthetic, it's difficult to chart. It can be difficult to feel. I mean, we do know that when we guesstimate, because it is a guesstimate of what the level is of the spinal cord using the iliac crest, we don't always get it. It's a guesstimate, but we don't want to go above L2-3. But if they're like finding the cardiac arrest of this patient is going to be difficult. But you do not want to cause damage to the patient's spinal cord. So you could perform the anaesthesia, but then you have someone who's damaged. So just always, when you're doing it, just always, and you might need to get the ultrasound out to actually count up the spaces. Sorry, anaesthesia. Sorry, Adam, I'm stealing some of your talk. Yeah. So I'll just. Oh, so I'm just going. These are some studies from the UK. It was Broadbank who did it, but there was an older anaesthetist, or she wasn't old when she wrote it, Felicity Reynolds in London, and she was excellent. She had some medical legal cases that she actually had to give evidence on. And so then they looked at where people thought the levels were, and the level was one space higher than assumed in 50% of these cases. So these are just normal patients, not obese patients. So it's important to, when you're doing the spinal, just to be aware. This is that's the same study. So look, it's been a bit quick. It's a lot of actually issues to actually think about. But I'll try to talk about the definitions, the implications, the trends of the incidents, and it's important public health to make sure the Indonesian population doesn't eat too many backers. No, because I know that's a worldwide trend. Think about the cardiovascular effects that I've talked about in relation to cardiac output and also its effect on the poor little myocytes with the adiposity. The effect on cardiac output and the changes with weight. Talked about the respiratory effects of the changes in the volume and the increased oxygen demand in pregnancy, and then when the lungs are compressed by also by the compliance of the chest wall and the abdomen. It's also important about aortic compression on the lungs, the heart and the lungs. Some of the bits about the gastric effects, renal, hematology, endocrine, with particularly diabetes, of gestational diabetes. But about the pharmacology, I thought that slide is actually quite good, looking at which drug to use, lean body weight and ideal body weight, and then a bit about the musculoskeletal. Okay, any questions? Or do we have questions at the end?
Question will be offered the second.
Yes, okay, yeah, that's much better.
Okay, give a round of applause to Dr. Kim. And we invite the second speaker.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Selamat pagi. Senang sekali bertemu, datang ke Malang dan bertemu dengan kalian semua. Terima kasih banyak untuk undangannya yang baik. Ini suatu kehormatan dan hak istimewa. Saya harap, semoga semuanya sudah makan pagi. Saya makan nasi buk dan nasi pecel hari ini dari hotel saya. Saya mencoba itu 2 kali. Makanan itu enak sekali. Berbicara tentang makanan Indonesia, Saya sangat suka makanan Indonesia dan pertama kali ketika saya di Bali, saya mencoba ayam betutu dengan saya sangat meremehkan rasa pedas makanan Indonesia dan makan ayam betutu dengan sambal mata. So tahunkan apa apa yang terjadi kepada saya setelah itu. Ayam betutu menambah rasa pedas. Saya seperti ayam betutu menambah rasa pedas. Ayam sambal mata menambah rasa pedas ayam betutu. Di kehamilan, kegemukan menambah fisiologis perubahan fisiologis di ibu dan memberi banyak masalah untuk anestesiologi yang malah. Inilah kita yang akan bicarakan dari kuliah saya ini. Terima kasih banyak untuk menyaksikan saya berlatih bahasa Indonesia kepada anak. Bolehkah saya melanjutkan presentasi saya di dalam bahasa Inggris sebagai form of Thank you very much indeed. So much of the topic is covered. Obesity already stresses the physiology. See that Kim has explained to you, and put patients and students at risk and requires interdisciplinary cooperation. And it affects not only the mom as well as for the baby as well as Kim has discussed. We get lots of problems, increase in gestation diabetes, hypertension, preeclampsia, so on, and also gets neonatal complications as well. It's just not for the mom, it's bad for the baby as well. So Kim has covered this, so I can just skip through this. I'm going to talk mainly, so the talk that I'm going to cover is mainly for the class 2 obesity, morbid obesity, like a BMI of 40 to 60, which is what we're covering about. Obesity is a great problem. In just 14 years in the US, you can see obesity has gone up 5 times and it's increasing. And it's just not a problem of a high-income country, it's a problem around the world as well. And as Kim has mentioned, Indonesia in 2030, we're going to be number 9, the number of with the amount the main for the most number of obese patients in the world from a female perspective, and from a male perspective, it's going to be number 13, most number of obese patients in the world. That's according to last year's obesity atlas, which Kim has shown you about. So why is the problem in pregnancy? Why obesity is a problem in pregnancy? French confidential inquiry in maternal deaths show that class 1 obesity got 2.5 times the chance of dying, class 2 and 3 obesity got 3.5 times the chance of dying. And this is the British confidential inquiry into maternal deaths. Over 50% of patients who died are obese. So much so that most of the colleges and associations around the world have asked for multidisciplinary involvement and asked for anesthetists to anticipate and manage challenges in obesity. It automatically generates more than 40, the BMI is more than 40 has to generate an anesthetic consult. And this is our anesthetic consult look like. So if you have prompts the midwife or the surgeon to send an anesthetic referral to us. But even though it's just a referral, it comes to us, we're so immune to BMI more than 40, we don't see these patients. We just entertain and see these patients only if the BMI is more than 50. So this is one of my regular anesthetic, and Kim would say that it's not regular anesthetic. So as long as the airway, breathing, and circulating is smart, I'm happy. So I don't know. Do I know the challenges the surgeons face in this surgery? Maybe, maybe not. The same way, it's a survey done by, do the obstetricians know the challenges that we face from an obstetric perspective, from an anesthetic perspective? This is a survey given to the some obstetricians in Ann Arbor in Michigan, and only 100%. only thing that the obstetricians knew that in obesity that anesthetic might feel is difficult venous access. They didn't know that the patient, the obstetricians didn't know that there is a higher risk that epidural failure, there's a higher risk that epidural can be inserted, can be difficult epidural insertion. They didn't know about difficult intrathecal intubation, didn't know about respiratory quality of OPIs and gastric things. So that's the importance of we seeing these patients beforehand to assess these patients, because obstetricians are not going to do anything with you, and it mustn't come as a surprise. So that's the quality. That's why we need to see these patients beforehand. So what we do, as usual, airway breathing, look at difficult airway, sleep apnea or not, to see whether they got hypertension, cardiomyopathy, all these things that you normally do. I don't have to teach you these things, all your routine anesthetic assessment. And also examination of spine, identify patient with neurology. Challenging use ultrasound. Do you guys use ultrasound for your backs? Do you do ultrasound for your backs?
Sometimes.
Sometimes, yeah. So a quick course, on how to do ultrasound on the back. Right? So there are some QR codes which you. There are some QR codes that you might want to scan, which is linked to articles and stuff. Right? So there's one QR code of this article. So two views that what you normally use for. So the first view that we use is a paramedian sagittal view, where we use a curvilinear probe for this, because we need a depth. So the linear probe is not good for depth. It's good for superficial structures, not good for deep structures. Use a curvilinear probe for ultrasound of the back. So you look at the back, it's a paramedian view. So the sacrum could be a straight line. And then you see the lamina, this is L5S1, then you see the lamina, this is L4-5, this is the ligament different, this is the ligament flavum. And this is what you are expecting for the sacrum of the straight line. So you count the space from below, the sacrum straight line, then it's a break, you get a ligament flavum here, then it's a lamina, you get a break, this is a ligament flavum. And an artist impression looks like Gigi Girgaji, right? It looks like a sawtooth. The crest of your the sawtooth is the lowermost part of your lamina. So this is the lowermost part of the lamina. That's the crest of the lamina, and the trough of the lamina is the ligament flavus. So that's why it gets that like a sawtooth pattern. All right. So you count from below, and then once you reach a certain level, you would turn the probe horizontally. All right. So and then you can see. So when you are on a spinal process, you get a huge shadow behind it. As a spinal, you get a shadow underneath it. And then what you would see is then you just go, just like when you do a spinal, you just angulate the probe upside and see what you get. So what you're looking for there is you'll come and get the articular process, the transverse process, and then the ligamental flavum, and then the dura. So this is what this is a view that you're looking for. And it even gets better when you're looking for a pattern, wouldn't you? So we are good at patterns, pattern recognition. So it looks like it's a flying bat. So can you see a bat here now? This is a bat, isn't it? This is an artist impression, but can you see a bat? This is the ear of the bat. This is the forehead of the bat. This is the nose of the bat. And these are the wings of the bat. All right? You see a bat now. So this is a pattern that you're looking for. If you're looking at a pattern to this, it would mean that you can have it's a good view of the bat, and so it doesn't take that long. I can just have to look at this, and then you can see the ears, the nose, and the ligament and flavum and the dura. That's your, and then that will give you an idea. So then drop a caliper from here to here, then see how that is the problem. And then when you get and then you get the depth of the ligament flavum. So, and when you get that, you draw a line here and draw a line there and draw there, and join us to the next spot. All right. So, and remember the angle when you get a nice view, and that would be the angle that you insert it. Sometimes you may have to angulate the probe a bit more horizontally. So remember that angle in your head. You X-marks the spot, and that angulation is close. And most of the time that's very well. So this is a QR code that you might want to scan, and that gives you a link to the article, that gives you much better use of these things. All right. So we let them know that there's an increased risk of dysfunction labors, tell the patient of all the risks that can happen, and reassure them that we will take good care of them, we take special modification to minimize to maximize the safety of the baby. And this is one of the pamphlets that we normally give. Like, we can easily download it from legopage.org. We have our own version of this, but for you guys, if you want to, there's a QR code if you want to scan, and that's one of the things that we give to high patients with high BMI, where it sort of explains to the patient that things can be difficult in early epidural if need be, and things like that. So the logistics of managing these patients can be challenging. You need to have consultants on board, anesthesia and neonatal teams, everything on site, adequate humidification staffing and appropriate equipment. So much so that this is a South Australian guideline, the state that Kim and I come from. If you have a patient of BMI more than 45, they have to come to the city to deliver. They can't deliver in the country. So they have to be delivered in a maternal 4, 5, 6 units where obstetricians on site, neonatologists on site, anesthetists on site, and things like that. The BMI more than 60, they have to be delivered in a center with an on-site intensive care unit. They can't deliver in a hospital. So Kim works in a hospital where got intensive care units that they have. In my hospital, there is a pediatric intensive care unit, but the adult intensive care unit is not as developed. So we may have to refer some of the patients to hospitals where Kim works. So you need to have all this equipment, video laryngoscopes, blood pressure cuffs, increased blood pressure cuff, big cuffs, ultrasound machines, arterial lines, because blood pressure cuff may not be enough, so put an arterial line then with an ultrasound guidance maybe. And this is a hover mat that we use to move patients. This generates a lot of pressure inside, so this generates, so can you go back? Yeah, so this generates a lot of pressure or pressurized air, and underneath that is minute holes. So when you generate pressure, the air, through that holes, lots of air would go on higher pressure and creates a small film of air underneath the bed and the table, under this mattress and the table. The patient lying on this can literally glide across. Literally, two people can move the patient, even the patient at BMI 50, 60. This pressure is called a hover mat. So it's one of the things that we use. And needless to say, long epidural spinals. So anesthetic management, needless to say, neuraxial anesthesia gives you the best quality of pain relief. Conversion to surgical anesthesia. Epidural is the best with modifications like combined spinal epidural anesthesia, CSC, or dual puncture epidural anesthesia, which we will talk about in a second. It's called DPE, which is getting more and more popular amongst obstetric anesthesia. Needless to say, epidurals can be challenging. As Kim told you, sitting positions preferred, using ultrasound, long epidural needles, constant communication with the patient, and fix the catheter after getting the patient to sit straight. Otherwise, if you fix the catheter of the patient like this, there will be lots of fat which gets redistributed when the patient sits forwards, and if it's already fixed, the epidural can migrate up. Right? So fix the catheter, fitting the patient out. If you don't have, so another rule of thumb is from the C7 spinous process, you draw down to gluteal hold, and then if you don't have an ultrasound, lowest part of the gluteal fold, you can just draw a line like this, and that would be X marking the spot, and see a midline, and then to do something in cases where you don't have an ultrasound. So we maintain, so analgesia, we maintain with patient controlled epidural analgesia with a dilute local anesthetic solution with a programmed intermittent epidural boluses, which we'll talk about in a second. So programmed intermittent boluses is just simple. It means like if you give 10 mils per hour or 10 mils every hour, those are two different things. Even though the patient gets the same dose every hour. 10 mils per hour is you get a small puddle of local anesthetic going in, drop and drop and drop, and forms a small puddle like this. Sorry, can you go? And you get a small puddle like this. But if you get 10 mils every hour or bolus every hour, it means that every hour you get a constant solution going in, pressure, and that sort of opens up the epidural space and improves the quality of the spread of the anesthetic. So usually give not as an infusion as boluses. So either patient pushes and get the bolus, and the machine gets intermittent bolus programmed every hour. So this is our chart that Kim has developed, and it's a long-standing thing. You can see Kim's signature at the bottom. So our order is a PCA dose of, we use 0.1% ropivacaine, 2 microgram per ml of fentanyl for our epidurals. 10 mils every 20 minutes is the PCEA dose. The patient can have 10 mils of that every 20 minutes. And on top of that, every hour, the machine gives a bolus of 5 mils. So that is the PIEV, or the programmed immunology epidural bolus component. All right. On top of that, the midwife can give an extra bolus of 10 mils in the same thing. So this is our order of labor analgesia, patient control. So as you can see, every hour you can get a final bolus, final bolus, final bolus, like that. And if the final bolus comes very close, if the patient just before the PCA, the PIEB gets delayed. So machine programs in a way. So combined spinal epidural anesthesia is you do an epidural through that you pass a spinal needle and put some local anesthetic through that spinal needle. The patient gets comfortable, and then you put the epidural catheter in through that same needle. All right, so that's a technique that's used to get quick analgesia. But the problem with that is you put local anesthetic in the spinal space, the patient gets quite comfortable very quickly to a stage that if you put an epidural catheter in, you don't have an idea where the epidural catheter goes. All right, whether the epidural catheter works or not, and we don't want to come back. That's why these people have developed a technique called dural puncture epidural. They do a spinal epidural, through that you pass a spinal needle. Don't put anything through it. Take the needle out, just create a hole. And that hole will act as a conduit for local anesthetic to go inside and give a better quality of pain relief later on. And you can still test the epidural catheter. So you put the epidural catheter into the epidural space, take it out, and the local anesthetic from the epidural can go through the spinal anesthetic, as shown in these studies. Like the local anesthetic from the epidural catheter can go inside. If you have a 24 gauge and above, they can go through that hole and give pain relief through it, as well as taxan epidural. So it's sort of a middle ground between a CSC and an epidural. So of course, these patients have a higher risk of accidental pleural puncture. 4% in normal versus 1%. But whether they get headaches or not, because the epidural space, I'll show you later, that is quite squished with lots of fat in obese patients. So the pressure, intraepidural pressure is quite high. So in BMI more than 50, I think the incidence of epidural post-dural puncture headache is reasonably low in this population. So we need to meticulously manage these epidural catheters, troubleshoot them very quickly, because it can, like if you need a GA, we need that epidural to work nicely. So you need to troubleshoot them, meticulously manage this patient. Other techniques that can use are not as effective as epidural, like Entonox, opioids. Then you might worsen the obstructive sleep apnea, and non-pharmacological techniques like thymosin acupuncture. The effectiveness is improved. So you need to anesthetize this patient for a cesarean section. Regardless of whether you're giving a GA or a neuraxial, you need to remember left lateral tilt, you need to remember acid aspiration prophylaxis, and also, as Kim has mentioned, ramp this patient up. So it improves respiratory mechanism, easy to insert laryngeal. So decreases aspiration risk and increases your laryngeal view. Just because you are, if you know the physics of intubation, you've got the oral axis, laryngeal axis, and pharyngeal axis, which got aligned. Unless these three axes align by flexing the atlanto-occipital joint by keeping a pillow under the head and tilting the head back, then you get all these axes, oral axis, pharyngeal axis, laryngeal axis align, and then pull this mandible up and you can see nicely. All right? In an obese patient, the head just hangs off the pillow. This is just in a normal patient. In the obese patient, head just hangs off the pillow like this, you can see. So that's why King's mentioned the line between the ear and the sternal notch, the tragus and the sternal notch, has to be parallel to the floor like that. Oh, sorry, can you go back? Sorry. That has to be parallel to the floor. So that's what King's mentioned. So that's why ramping is needed. So that would align these axes. So if you look at this patient, the head just hangs off the pillow, and this is the laryngeal axis. The laryngeal axis looking inferior. So if you're going to intubate this patient like that, you need to come from below to intubate this patient. You're making your life more difficult. So when you ramp this patient up, you can see the laryngeal axis is coming from this way, is coming up a little high. And if you tilt it back, if the patient, and this goes up a little bit more, this axis is more aligned and you get a top. So that's the beauty of aligning. The endpoint is this line. of the tragus to the sternal notch has to be absolutely parallel to the foot. You can either use this or you can use stables to ramp these patients up. So that's very, very important. And as Kim has mentioned, there are a lot of fat in the around the waist. So what would happen is they can tilt the spine down. The spine lower down will be higher than the patient has in the back. So you can get the spinal can go higher in these patients quite quickly because they have a relative temporal inverted position in obesity. As Kim has mentioned, this is something that we use to retract the panniculus. So they have it's called a traxi or a panniculus retractor. What it does is just you stick it there and then pull it over the patient's chest. And that would cause compression, like we've got compression, arterial compression, hypertension. It increases intraabdominal pressure. It's easy for the surgeon, but not good for us. All right, so they can, when they retract that, they can see there's a good access to the panniculus. No one has to retract it. But there is a large level of spine, and you need to be wary about those things. Antibiotics, as Kim has mentioned already, we use increased dose of antibiotics, more than 120 kilograms, 3 grams of capsule is given. Antibiotics 2 hours, and continuing 24 hours. And options for anesthesia is continuous single shot spinal epidural CSC or a continuous spinal cap or a general anesthesia. So these things. Can you just go back? That's what I mentioned before. This is an MRI study. This is a patient who's normal, but in pregnancy you can see a lot of fat encroaching into the epidural space. All right, you can see a lot of fat through the tract. It's a inward movement of soft tissues through the intervertebral foramen into the CSF. That displaces the CSF. That squishes the epidural space in pregnancy because of increased abdominal pressure of pregnancy. A lot of fat comes through that. So essentially, for patients more than 50, BMI more than 50, your dosage of spinal anesthetic has to be reduced. All right. Otherwise, if you put a normal dose, you can get a high spinal in these patients. But so the single shot anesthesia is simple, like you can do a single shot. Sometimes you need to do an epidural catheter to insert the spinal. Well, the problem is how much do you need? That's often a question. How low can you go? So best in these situations do a combined spinal epidural. That's the technique of choice in morbid obesity. So do a combined spinal epidural and probably decrease the dose about 75%, and then use your epidural catheter to squish, top it up and raise the block up further if needed. And that epidural catheter will act, because if it's difficult for you, it's going to be difficult for the surgeons as well to operate the surgery. So surgery is going to be prolonged. So epidural catheter will save you from converting this patient to have a general anesthesia. So who wants to intubate this patient? Who wants to intubate? This is the patient's Mallampati. This Mallampati is patient lying like that. That's the neck, single neck, some single. You don't want to intubate this patient at any cost, don't you? So if for a cesarean section, so spinal may work and might take some time. Epidural, and if you've done cesareans with an epidural, epidural is not good as spinal anesthesia. You need to have a sure shot technique that you want to avoid general anesthesia. In these circumstances, they recommend intrathecal catheter and use that as a continuous spinal anesthesia. Right? So you put an intrathecal catheter, use a spinal which can give you and put a catheter, do a deliberate dural puncture, put an intrathecal catheter through it, and then slowly top it up. And if it wears off, you can top it up again. And it works better than an epidural by itself, and you can avoid giving it again. Not that I've done any deliberately, right? And the risk of PDPH has to be weighed with benefits of avoiding difficult area interventions in these patients. Changes in surgical techniques, a double epidural catheter is being described in literature. That's where we have a big panniculus. They use a supraumbilical incision, and to give better coverage, they've described a thoracic and a lumbar epidural catheter in these sort of circumstances to get better coverage. Not that I've done it, so just putting it out there. General anesthesia. You need to have emphasis on patient positioning, have adequate CDO personnel, critical area intubation. Pre-oxygenation is a must. Use CPAP, high flow oxygen, or apneic oxygenation. All those things are described to improve, as Kim has mentioned. General anesthesia, as Kim has mentioned, I just skipped through, is based on lead body weight, intubation, laryngoscope, fiber optic intubation. extubation is done, the patient awake, sitting up, go straight on high flow oxygen and decrease and improves, or on CPAP. Pain relief is very important in these sort of circumstances. We try to keep it simple. Everyone, if possible, gets epidural or spinal anesthesia, spinal morphine with regular Panadol and non-steroids. So what we give is intrathecal about 50 to 150 micrograms of preservative-free morphine is given. That gives good quality pain for 16 to 18 hours. So we don't need any systemic analgesia after that. It's increased incidence of respiratory depression even in morbidly obese, and overstay neuraxial opioid. Have closer monitoring for 24 hours. And blocks, if you have an intrathecal morphine, blocks are not as good, they say. It's comparable to pain. You're not having any advantage by doing a tap block or or a quadratus lumbar block in these sort of circumstances. So multiple analgesics, multimodal analgesia, minimal systemic opioids, decreased delivery through breast milk. We use a very, very slow dose of local anesthetic, 2.5 to 5 milligrams too early. That equates to 1 to 3. So our logic is giving, we've done an audit and we found out that giving small doses, quite regularly, in smaller intervals, gives better quality of pain relief, and they decrease the use of, the total use can be decreased. So if we published an audit which shows that using 2.5 to 5 milligrams too early, the average use is about 7.5 milligrams. That equates about 2 or 3 milligrams of morphine a day, intravenous morphine a day. So, and then patients were quite, we followed that with another audit, and the patients were quite comfortable with these. So, infection, thromboembolism, respiratory compromise can happen. Thromboprophylaxis is a must in these patients, either pharmacological or mechanical, like stockings, compression device, heparin, enoxaparin or heparin. So, in summary, maternal obesity is growing alarmingly high in rate in a worldwide. There can be adverse outcome in both mother and baby. Clinical logistical challenges there. Careful planning will improve maternal and neonatal safety. Poses anesthetic challenges, analgesia and operative both analgesia and operative delivery. Antenatal anesthesia consultations are must. Neuraxial analgesia and anesthesia is preferred in these patients. Need to have involvement of experienced senior clinical person, and multidisciplinary team involvement is successful, and communications for successful management of this patient. So I'll stop this with a snip of a wonderful person from a future generation who's looking at this weight, and hopefully they can decrease the who looks at the weight and decrease the incidence of obesity in the future generation. Hopefully we don't have to deal with it. Matur nuwun singgah. Assalamualaikum warahmatullahi wabarakatuh.
Please permission to join Dr. Anuraju. Please visit in front. And then we have a discussion session. Please raise your hand. 1, 2, 3, 4, 3. The first 3, right? It's okay. The first one is Dr. Gentry.
If they want to, they can ask in Bahasa and you can translate it. So, no, seriously. And then one of you can translate. Be apprehensive, you can ask your questions in Bahasa and one of you can translate.
They're learning about the English.
Yeah, no.
Dr. Prima is good in English.
No, I was asking, normally when you come there, people won't ask questions because they don't want to.
Yes.
So that's why I was telling you, it's not like you don't have to speak in English. Again, if you want to. So
Thank you for your opportunity. First, I say thank you to Dr. Kim and Dr. Anuraju. Your presentation is motivate me to be on diet again. That's my question. Jadi pertanyaan saya, Dok, is there any safety rate of BMI to get pregnant? You can say what I mean. Yes, because first I don't want to be on diet when I'm pregnant first.
Hmm.
So the second one,
Yeah.
I don't want any danger or high risk situation to my baby when I'm pregnant. Is there any link to BMI? Because kalau yang saya lihat tadi, yang paling bahaya BMI atau BMI over 40. Thanks God, I'm not that. But I'm in obese situation. Yeah, class 1, I think. So, is there any safety rank in your department or in your place that we can educate the woman to be safety to get pregnant?
Maybe based on physiology change.
Yes.
What kind of BME range to safe to get pregnant for women? Based on maybe
Safety BMI.
yes, low over than 30, below than 40 or something like that.
I don't think there is a safety range like that's recommended.
There's no recommended safety range. What this data shows that if you have a class 2 obesity, you got twice the chance of having complications. Like if you have more than 35, you get twice the chance of complication and mortality and morbidity. And with BMI more than class 3 obesity, more than 40, then you got about thrice the chance of having three and a half chance of having morbidity and mortality. But the higher the BMI goes, the more the chance of complication happens. But there is no recommended safety BMI, safe BMI to say, yeah, this BMI you're safe to get pregnant, this BMI not safe to get pregnant. So just maintain a healthy weight and that should be fine. And anesthesia these days are very, very safe. Now all these risks are noted not from an anesthetic mortality. So anesthetic mortality is very, very, very rare, even with patients with high BMI, with all the equipment that we have, all the facilities that we have. I think it's very, very safe these days, and maternal health care delivery too. So I don't think, to answer your question, I don't think there is a safety range that I know of which has been recommended. So
how about you?
I agree with Anu, but if you're the patient, they, antenatally, they won't be thinking about anesthesia risk. The patient won't be. But what they may be more focused, that may focus them on, is gestational diabetes and the effect of gestational diabetes on the baby's growth and the baby's outcome and the greater risk of infections and labour. And we know in Australia, the definitions of gestational diabetes have changed slightly so that we diagnose it more. So your question was about the patient. What are the exactly? There's no magic number. But just say to the patient, look, if you do getting more obese or gaining some weight, you don't have to be obese. You just have to gain more. But the incidence of gestational diabetes, which will have effects on potentially effects on the baby and how your labour is managed, is a focus on the patient.
Yes.
You know what I mean?
Thank God. We are all best, but we are not pregnant.
Oh my God. I wait you to say, it's okay if you were class 1 of obesity. But okay, I understand what you mean.
The answer is you must diet first.
Okay, thank you.
Yes. Okay.
I think just between you and me, you'll be fine. You'll be alright.
Okay. Next question. Okay. Next question. The man.
Assalamualaikum warahmatullahi wabarakatuh. Thank you, doctor, for your wonderful presentation. My name is Alpha. My question is about in some obese patient, we have the patient that anxious that maybe from difficult regular anesthesia from epidural or spinal, or maybe the situation in OR that they have not used to be, they are anxious. So, what is the best strategy for coping anxious patient, which is at high risk of OSA or maybe Pickwickian like hypoventilation syndrome and risk rapid desaturation in patient that is it if we want to sedate the patient in OR? So what is the best strategy? Maybe like increasing modality of oxygen with NRPM or giving in I think in Australia or in America using high flow nasal canal for oxygenation. And maybe it's we are worried about we giving sedation in patient or anxious patient in obesity patient. So
how do you manage? Enough?
Yeah.
Thank you.
I guess I don't know about you, Kim. I don't, for us, pre-medication is becoming more and more obsolete, especially in anxious patients and stuff. I don't know that I can't remember the last time I've given a pre-medication to a patient. Have you ever, especially for anxiolysis? I know you get a lot of anxiolytic patients. Pediatrics is different. For the best thing is, avoid your opioids if at all possible in this sort of circumstance. I understand what you mean. Sometimes your patients are quite anxious. So nothing beats going and talking to the patient, allay the anxiety, just reassure them, get the support person in. So we get support people as well. The husband usually comes into theater for cesarean section. So having a support person in, having a strong, a midwife, who are quite supportive. They speak to them, call them, hold their hand, just support them. Those things are commonly done, and that would take care of most of the patients, like an anxiety and all those things. But if you really, really need to sedate them, I'd stay away from opioids. Give a little bit of small dose of midazolam, something 1 milligram or half a milligram of midazolam. And if you are sedating, as you said, there is a risk of desaturation, hypertension, all those things. So start low, pre-medication is something that you don't want to bang in as a set dose, something that can give it, titrate it to effect. Like start with half a milligram or 1 milligram of midazolam, and then them on nasal high flow. Just start with some oxygen. Whenever you're doing that, just to prevent for safety reasons, give some oxygen, either a Hudson mask or nasal cannula, or if they are severely obese, then that's when you look at high flow cannulas and stuff like that. But in general circumstances, reassurance, holding hand, and titrate your opioid, your midazolam or benzodiazepines for anxiolysis. You really, really need it. And oxygen is a must in certain circumstances. So date in either in an HCU or a recovery area where there are monitoring facilities. Don't do it just in the ward or holding area. They don't have any monitoring facilities. If you do, as you said, you correctly pointed out, they can be unsafe.
Just like to reiterate exactly what Anu said about preparing the patient. And as you sort of said, often there are reasons why they feel anxious. So never rush. And sometimes ask them what their concerns are. And so think about reassure them how you can manage those concerns. But also, what I sometimes say to them is, although we're sort of in control of the theatre, they're in control of their emotions. So sometimes I can say, look, you're in control. You tell me how you're feeling. I'll give them a little bit of anxiolysis. Sometimes that can act as a bit of a placebo. Yeah. No, but you just say, look, you still give it. You don't give Ceylon. You still give it, and then you don't want to give too much, because once you've given it, you can't take it away. And the other thing is, because obstetrics and obstetric anesthesia is a team game, because you've got the surgeon, the nursing staff, and we have anaesthetic nurses with us. So if we've got a really anxious patient, we have before we do team time out, before the patient gets into the theatre, I say, this patient is going to be really anxious. Just bear with us, and the support person, as Anu said, they're really important. They know, I mean, they know the woman better than you do. You met the patient. So and often them holding their hand helps to reassure the patient. And the other thing one of my friends sort of get them to think about what the outcome is. So they're having an operation and they're getting a prize. They're getting a baby at the end. So instead of focusing on their anxiety, sometimes you can't say, you must do this. But say, you're going to have your baby soon. You're going to be able to see your baby. So sometimes changing the dynamic, the processes in their head to focus on the baby and the prize.
So do you mean the best is a pre-operation, right?
Yeah.
Pre-operation preparation for this patient. So compared to that, what is the best, neuraxial or general anesthesia, based on that, for pregnant patient?
Oh, neuraxial, hands down. unless there are any contraindications, no general anesthesia. Neuraxial, hands down, is the best. General anesthesia only as a last resort. The only contraindication, absolute contraindication, generally is the patient refusal. Right? All the others are sort of related to contraindication. You can get around it. And of course, there are other things like coagulopathy and all these things. So, other thing that you look at whether the patient can lie flat. That's another thing, all right? So if the patient can't lie flat, there's no way that you can do it. All right? Patient refusal, if the patient can't lie flat, especially an obese patient, they won't be able to lie flat. So morbidly obese patient, even if you sit them up, the surgeon can't operate. They may have to sit up. The closing capacity, as Kim has mentioned, when they lie flat, everything just pushes up, and the closing capacity go up, and then you become like those sort of circumstances. But if at all possible, we'll be trying to do it under a neuraxial blockade. Like combined spinal epidural is at least in my hands, the best technique in these sort of situations, so that you still have that reassurance of your epidural catheter. So you do a spinal and then put an epidural catheter in, and the surgery takes longer. You can use the epidural catheter to top this patient up. So I guess that's what my opinion is.
Because there's always advances. So in the last 10 years, the Traxi, that does make it easier that makes the surgery easier. But it's not as bad as where the intern used to push it up. So there's always and the other thing is the high flow oxygen, because that'll increase the functional residual capacity. So that will also help. And the beds, we've got beds that you can just wear just the chest wall, not to the bed, but just the little. So all those little advances do make it safer.
Okay, thank you. And then we still have time. Okay, the front. You go on ladies first.
Thank you for the lecture this morning. I want to ask if you go for spinal for obese patients, which size of needle you prefer? I mean, like sometimes when BMI 42, I could use the 27G, but the other time I with 43 or 44 BMI, it could be with spinal anesthesia is for 25G. Then maybe you have preference. Where is the which one which needle you prefer? The 25G or maybe 25?
Maybe based on your experience.
Yeah. I think you are an excellent operator. If you fact that you're doing a 27 gauge spine with a 27 gauge needle, so you'd be easily able to do that for all of BMI 40. I think well done. It's excellent. Good job. I guess our practice, it's mainly about the feel, isn't it? You always go with the feel. So, like in obese, as the patient gets bigger and bigger, you all feel like you're going through the ligaments and all those things. It's all about the feel that you know. It's hard to teach, but you know what I mean. So the smaller the needle, the lesser the feel, and the lesser the chance of your success. So the bigger the needle, you get higher chance of success. So the BMI goes more than 35. My default is probably 27 in BMI. To get a better feel, I am more comfortable using 25. That's my personal opinion. We use Vitec. What do you guys use? Vitec?
Yes.
Quick K, yeah. We use Vitec. We use Vitec needle, which is a blunt needle. So blunt. So you need to have an introducer first, and then you pass the needle through it. So we use the Vitec needle, 25, because it has decreased risk of osteopuncture. It's a pencil point.
Yeah.
So you have an introducer first. That's why it's so 27. So 25 would be is what we normally use generally and sometimes that because we use that the introducer and the needle can be sometimes difficult, so we have to get an epidural needle as an introducer for this. So get an epidural. So we just do it like a CSC, like do as an epidural, and through that we pop normal standard epidural, and through that we pass a long spinal needle. So we either use a kit which comes with a 27 gauge, or we use a long 25 gauge spinal needle with through an epidural. So we do an epidural, go through when we reach the epidural space, we pop a bigger spinal needle through it. So in my hands, at least 25 is better, is what I think. But it's all personal preference. It's all what you're used to. I don't think there is a guideline that says you need to use 25 times. So it's making your life easier. So to improve your chance of success is what we're looking for. I don't know what your opinion is.
I agree with that because we're using a pencil point needle, not a cutting needle, which is a quinky.
Yes.
Yeah. So so cutting needle might give you a little bit more feel, but it increases the risk too. But technically, what Artie was saying, when we have you can't reach.
Yeah.
So once I get to need a longer spiral needle,
We don't have.
yeah, and trying to do that with a little introducer is they go all over the place. It's hopeless. So that just re-emphasise Artie's point about using the epidural as an introducer in those instances, because you'll feel what you're doing this with your hand, and you want to feel what's actually happening at the end of that needle.
Yeah.
And the introducer helps guide, but it also, when it's in there, it decreases it makes it feel better, easier. And so once you've got all that fat that you go through, but by using the chewing needle, that'll improve your feel, as well as the direction of the needle.
So at least until you're going.
Rather than using 27, until you reach the epidural space, you are using an 18 gauge. You're increasing the feel, isn't it? So it's not that you're puncturing the dura with the 18 gauge, not puncturing the dura with the 18 gauge until the epidural. Actually, epidural space you go to the 18 gauge, and then through that you pass a 25 gauge. Alright, so that you're increasing your feel. So 18 gauge is better feel than a 27 gauge. So that's what it's not like. If you're feeling it well, it's good. It's not that.
Because sometimes I skin analysis for obese patients. It depends on my lucky that day. I mean, there's no preferences. Maybe 25 is more easy to
Feel.
feel the epidural space.
Do you guys have a curvilinear probe with your ultrasound machine?
Yeah.
Yeah, just take like with that article, just have a read through that article. It's not that hard to do. Like, just start practicing in normal patients. Just take a curvilinear approach. It takes about 10-15 seconds. Just have a look, like, just once you start doing it. The problem with the obese patients, to start to do it first in an obese patient, is need to know the anatomy. So the curvilinear probe is a low frequency probe. It gives you depth, but the problem is the deeper you go, the resolution is gone. So, when you use a curvilinear probe, so you need to have a good look at the normal anatomy first. So scan some normal backs. Next time you have cesarean section, take it in. Before you scan the back. Read that article, scan the back. Once the back is scanned, just do some markings if you want. And then when you start to get a bit of feel of anatomy, know what things are, then it becomes easier. Later on, when you have an obese patient, then you get a better knowledge of anatomy. So scan normal backs first.
Thank you so much.
Okay, thank you. Anybody?
And most of the time,
It's mainly when you go off the midline is when you get trouble with the spinal anesthesia. It's when you say you need to get lucky. So marking the back where the midline is very important. You might get deceived with the midline. You guys do sitting or lateral spine?
So that's for obesity. We prefer the sitting position.
Yeah, sitting position is best for obesity because when you lie on the side, the midline just sags down and you get deceived. Like, the midline just sags down and the midline is not where you think. The midline is not where you think the skin fold is. All right? So you get deceived by the midline. You're trying to go there and you're not going anywhere. So that's why sitting is preferred, like, better in this sort of circumstance. So you don't get deceived by the midline just sagging down the side.
Okay, thank you so much. Okay, last question.
Terima kasih Dr. Kim dan Dr. Raju. Presentasinya sangat bagus sekali. Saya Dadi, residen dari Anestesi Brawijaya. Mau menanyakan, yang pertama, apakah ada teknik untuk markering ketika kita melakukan spinal atau neuroaxial anesthesia?
Do you have a marker to do a spinal or epidural anesthesia? The first one.
Karena terkadang kita kesusahan pada pasien-pasien obes, apalagi dengan gravida. Di salah satu slide disebutkan kita bisa menggunakan USG, tapi USG kan operator dependent tentunya.
Okay. Marker to do a spinal anesthesia or epidural anesthesia, because sometimes we don't good enough to do a USG ultrasound, to do a marker.
Yeah, to do a marker.
No. So you refer to do a ultrasound, right? To do a marker, but is there?
If we don't have
yes, if we don't have a USG,
like a specific marker for the obesity with pregnancy patient without
a USG ultrasound.
Without an ultrasound, I guess if you don't have an ultrasound, we just go with the feel. So I don't think, like, as you said, sometimes feel can be difficult. So C7 spinous process, as to show to my talk, that C7 to gluteal fold, we just put a mark, and then the top of the gluteus, your gluteal fold, you put a mark, and then that sort of gives you sort of a midline. Is that what you mean, or you meant marker in the sense of what BMI cutoff and stuff? Is that what?
A marker to puncture the spinal and epidural anesthesia.
So without the epidural, we just go with the feel and stuff. And without the ultrasound, we have to go with the feel. Otherwise, you can put a small mark from the top to bottom. And then, as I showed in my picture, from C7 to gluteal fold, and on top to gluteal fold.
Hopefully, you won't have this. Okay. But every the BMI, the super obese over 50, say, if they've got it's all here, all the obesity here, and you can't feel, and you just can't get in lower down with the spinal, and for a cesarean, you could always do the epidural higher, where you're not going to do a spinal. You could, because that may, sometimes the fat's all here, you know, if you could go, say, L12, maybe to do an epidural, but not a spinal. And then but it would take longer to do the epidural to top up the epidural for the severe, but that would take longer. You don't want to start that early. You'd have to get up to the same level. But hopefully you wouldn't have that situation here.
Last question.
Last question. Okay. Last question.
How about the performing the spinal thoracal? Because the spinal segmental thoracal right now is getting popular in Indonesia. Now I saw a lot of the videos in India during performing the spinal thoracal for mastectomy or something. Is it possible? Because when I saw your slide, the level of the fat collection is merely in the lower back, lower part of the body, right? It's just like in the gluteus or something.
Yeah.
When we saw the back of the upper back of the body, it's like there is no fat dominantly in the center of the area.
Yeah.
Because I just think about if we afraid doing the intubation, if we failed performing the regional anesthesia, neuroaxial anesthesia, and then we afraid to do the intubation for the patient because of the risk of difficulty in intubation. Is there any chance that we can use the spinal segmental thoracal? Maybe this is just in our opinion. This is just in my craziest opinion.
Yeah,
Thank you.
I think the question you asked, one is, I don't know, I haven't heard of any thoracic spinals. You do a lot of thoracic epidurals, but you need to be very, very brave. I don't think I'm very brave to put my needle in that spinal space.
That's the point.
In the thoracic area, and I don't know. You don't have any control of what happens to the tip of the needle. Hopefully it goes and stays in the CSF. Like, you know, the number of times you get patients flinching when you do a spinal. Is because there's a cord that's going to damage the spinal cord, and you're going to inject the whole local anesthetic there, and then they might end up with a syringe.
That's the point. But in India, I saw a lot of anesthesiologists perform the spinal thoracal, and then the Indonesian is just like getting the popular right now.
I think the first thing is you need to keep the patient safe. I don't think in my hands that technique is a safe technique for the patient, because I'm worried about creating more harm to the patient. The patient, you might be able to get away with the patient, but the patient has to walk out of the hospital. You might be able to do a cesarean section. What's going to happen after that? You are increasing that chance. And more than that, you just need a level of T10 to T4 level for your. You need more sacral coverage rather than thoracic coverage. Might be good for mastectomy, but may not be good for sacral coverage in these sort of circumstances. That's fine. And there is a higher chance of higher block as well.
For mastectomy, this is a lower dose of the local anesthetic. But in my opinion, if we cannot intubate the patient, once we cannot intubate once we cannot ventilate the patient, we have to waking up the patient, right? So we have to get the alternative way to perform the surgery without intubate the patient. So
why don't you just do a lumbar, as I said, intrathecal catheter or something at the lumbar region? I'd be good. Or just a thoracic spinal, and then you can tie a thoracic epidural. But the thing is, thoracic epidural is more difficult than lumbar epidural because of the spinal, the spinous process or related stuff.
Okay, then. I'm not an expert, but I think in America or some in Europe, they may be using paravertebral blocks, doing mastectomies under paravertebral blocks. So, and then the risk of neuraxial damage is significantly decreased. I'm not an expert on those, but that's another technique to. But also, once again, the patient would have to be prepared because they come into the hospital thinking they're pretty going to be asleep.
Thank you.
Okay, thank you. we're happy that discussion session is full of enthusiasm. But the end time will separate us to do make this lecture anymore. Okay, so now we go for photo session. Maybe you can go back to your seat. Okay. So first, yes. Okay. One, two, three. One more. Okay, thank you. Okay, we have a gift to you.
No, you guys have seat.
Oh, okay.
Take a selfie.
You want to take a selfie, right?
Yeah, why not? Come on. All of us. Alright, 1, 2, 3. 1, 2, 3. Alright.
Okay. Thank you. Please, Dr. Anu, Dr. Kim, in front of our class. And then we hope that Dr. Isgati to give us souvenir. Please, Dr. Anu first. And the second one is Dr. Kim. Please join with us, Dr. Rudiantono. Yes.
Yeah, thank you.
Okay, thank you for all the participants for today. Let me, before we end of this meeting, let me finish this meeting with doa. Subhanakallahumma wa bihamdika asyhadu an la ilaha illa anta astaghfiruka wa atubu ilaik. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. See you next time. Sampai jumpa lagi.